Today I'll be talking about genetic testing in patients with gynecologic cancers. I have no conflicts of interest. Briefly, I'll be talking about genetic testing basics, genetic testing goals, genetic testing in the practice of gynecologic cancer care, specifically looking at ovarian, cervix, and endometrial cancers. And then I have a proposal on an expanded role of genetic testing in endometrial cancer. Genetic testing itself can be conducted in what we would call germline testing, looking for inherited genes inherited from a patient's family members, or else specifically looking at somatic or acquired genes, which can be present at just certain affected tissues. Specifically, in my world, what would be a patient's tumor. Now, we can perform genetic testing a couple of different ways, the majority of which is done through DNA tests, which can be done through either FISH or Sanger sequencing or whole genome sequencing, which are mostly now just in the research setting. And now in the care delivery setting are usually done through commercial whole exome or next generation sequencing tests. It is important to note that these are somewhat slower, requiring about 10 weeks. They can be costly, costing up to $4,000 to $7,000, but they are certainly comprehensive. Now, also available to us are looking at the downstream products of specific gene loci, and these would be conducted through protein-based tests or immunohistochemistry or IHC tests. These are fast and cheap, but unfortunately, they're very limited in their scope, looking at only one specific protein. Now, the goals of genetic testing kind of track along the different types of testing. So, in germline testing, we're hoping that we can then identify specific high-risk cancers within the patient themselves who is being tested, and can then engage in either prevention or surveillance for those high-risk cancers. And then we can test that patient's family member using what we call a cascade testing paradigm, and can then engage in prevention and surveillance of those patients' family members to benefit the population. Within somatic testing, this is usually done in the setting of helping with diagnosis, but can also help for identifying certain indicated therapies. Now, looking at the specific practice patterns for epithelial ovarian cancer, we do indeed perform IHC protein testing for a p53 protein, which helps us with the diagnosis of the specific type of ovarian cancer. And then for over a decade, we've been calling for universal germline testing for the BRCA and other breast and ovarian cancer genes. This is conducted on a panel next generation sequencing test. If that is negative in a patient with an epithelial ovarian cancer, then we will move on to somatic testing, looking for these BRCA and the other panel of genes, as well as something called HRD. And if we find that, or in either the germline or the somatic testing, then the patient likely would benefit from something called a PARP inhibitor given as a maintenance therapy after completion of surgery and chemotherapy. In cervix cancer, genetic testing can be used in the diagnosis, specifically looking for E6 and E7 proteins that are related to the HPV virus. And then looking for therapeutic implications, we'll test for something called PDL1 to see if it's present at a high enough level on the tumor surface that the patient would likely benefit from pembrolizumab therapy. Now, for endometrial cancer, we first will engage in somatic testing for kind of the same name or different names rather, for the same thing, which is HRD, MMRD, or Lynch syndrome proteins. This is done through universal IHC protein testing on a slide of the patient's tumor. And then this is followed up with next generation sequencing if we do find the protein abnormalities to see if the patient does suffer from a germline mutation. If they do suffer from the germline mutation, then we can engage in risk reduction and surveillance of different Lynch cancers, and can then also engage in that cascade testing to hopefully then benefit the patient's family member as well on a population level. Now, if the patient is unfortunate enough to have a recurrent endometrial cancer, we know that any of these specific mutations would likely indicate a benefit from pembrolizumab therapy. Now, endometrial cancer is typically defined by histology, and the vast majority of which are a specific endometrioid histology of cancer. Yet we know that though it's a large proportion of the cancers, they all have different unpredictable behaviors with differing survival risks and differencing recurrence risks as well. Now, almost a decade ago, a study was conducted within the Cancer Genome Atlas, which performed a cluster analysis to identify four key molecular subtypes of endometrial cancers, shown here with the different colors. 2 years later, this was then conducted on a population level within Canada, actually, which then confirmed these four different molecular subtypes and came up with a testing strategy using both IHC tests and next generation sequencing. These tests then held true, performing these molecular subtypes to then show that they have four very distinct survival patterns shown in the Kaplan-Meier curve at the right. Now, this molecular subtyping, though called for years ago, really was most recently last year indicated to be performed in higher risk cancers by our own NCCN. And then always ahead of us a bit, the European guidelines also were accompanied with some treatment recommendations that vary based on the patient's tumor's molecular subtype. Yet few centers are performing this universal subtyping, ourselves included, are guilty of not performing this yet. And it's likely because, as I had said, the mixture of protein and NGS testing, really the NGS testing is the bottleneck here because it can be both costly and time consuming. So I have a project proposing to identify the most cost-effective strategy of assigning these promised subtypes in higher risk endometrial cancers, getting us in line with the NCCN guidelines. And we'll be conducting a cost-effectiveness analysis using existing data. And I hypothesized that a novel targeted sequential staining and sequencing strategy will be the most cost-effective. Next, I want to measure the relative risk of recurrence for promised subtypes in patients with clinical pathologically considered low risk endometrial cancers who typically don't receive any adjuvant therapy. I'll be conducting a nested case control study of these low risk patients from the University of Utah as well as IHC hospitals. I'm hypothesizing that the rare and more aggressive P53 abnormal subtype will indeed have the highest risk of recurrence. Next steps after this project will be to implement then the most cost-effective strategy in high-risk cancers here at the Huntsman and IHC, as well as then, if the second name pans out, to then perform universal molecular subtyping for all patients with endometrial cancer, with the goal of delivering population precision medicine to decrease unnecessary treatments, but also decrease the recurrence and improve endometrial cancer survival outcomes. I want to acknowledge the following sources as well as mentors. Thank you.